Support for the Study Smarter series and this message is brought to you by Med School Coach. You ever wonder why Step 1 is so important? Later in this episode, we'll hear from Sahil Mehta, founder of Med School Coach, to hear his thoughts on why Step 1 is so important. You can go to medschoolcoach.com/ITB for a 10% discount on their tutoring services. Welcome to the show.
Welcome to the Inside the Boards podcast, the podcast dedicated to helping you learn to think like a question writer so you can study smarter, not harder, and succeed in medical school.
In this episode of our Study Smarter series, we are finishing up our discussion between Stuart Bryant and Greg Rodden from the Med School Phys podcast, discussing cardiovascular physiology. If you like the Study Smarter series and what we are doing, please subscribe to the show on iTunes and leave a rating and a review. You can get an ad-free version of the 2017 Study Smarter series for the USMLE Step 1 and COMLEX Level 1 while supporting the ITB podcast. Just go to our website, insidetheboards.com, and click on the Support the ITB podcast button on the front page. Don't forget to share this with your friends or connect with us on social media. On Instagram and Facebook, we are Inside the Boards, or you can follow and tweet at me at Boards Insider on Twitter. Thanks for listening, and happy studying. All right, so we're here with another Med School Coach Minute with Sahil Mehta, who is the founder and CEO of Med School Coach, the premier medical education tutoring and admissions consulting company that has helped nearly 9,000 students get into and get through medical school. Sahil, why is Step 1 so important for a medical student?
Yeah, so I think there's a lot of reasons for Step 1 to be super important, but the most is, I would say, residency placement. Step 1 really determines residency placement in a huge way. If you look at how a program director evaluates individual applicants who are coming into their program or applying to their program, it's really hard for them to sort by things like letters of recommendation. Obviously, a lot of people have great letters of recommendation. It's even really difficult in medical school to sort by grades, right? Because obviously medical schools don't have one standardized grading system. And so while there's a dean's letter, it's not a sortable function. The only thing actually on ERAS, believe it or not, that's sortable is your USMLE score. And so it's really easy for a program director to hit the sort button by USMLE score and essentially work their way from top to bottom, realizing that the people with the highest score are obviously the ones that they're going to spend the most time on. It's also really easy for them to simply filter by score. So if they have 1,000 candidates, they need to filter those out relatively quickly. And the way they do that is through the Step 1 scores. And so your Step 1 score as a medical student really determines what specialty you can get into, as well as the competitiveness of the program or the desirability of the program that you're looking for a particular specialty. So even if you're looking for, let's say, internal medicine, which overall may not be the most competitive specialty, if you're looking to go to Brigham and Women's or MGH or Hopkins or internal medicine, then you definitely need a really high Step 1 score. Obviously, if you want to go into a thing like orthopedic surgery or plastic surgery, then Step 1 score, no matter where you are applying to, is extremely important. So, that's really the reason I say that Step 1 is so important, because it allows residency program directors to determine who they're going to interview and who they're not going to interview, and it plays a really big role. And there's no other test, probably in any other specialty, in any other field, that plays such an important role in sort of where you can practice or what you can practice in your future. Because really, if you don't get a prerequisite Step 1 score, orthopedic surgery, dermatology, plastic surgery, those things may be totally off the books for you as a medical student. And so what I always tell students is, listen, you want to maximize your score as much as possible in order to have all these options open 2 years from now when you actually go apply to residency.
You're saying it's a necessary evil.
Yeah, for sure. I mean, tests, I agree, definitely evil, particularly in the medical space. But, of all the tests that we take to get into and through medical school, obviously the MCAT is hugely important in getting into medical school. But once you get into med school, this is the most important test just in terms of numbers, right? I mean, step 2, step 3, much less important. Even your boards, I mean, those things are pass fail at the end of the day. But step 1, while it is pass fail, obviously the individual score that you achieve on that is just so important because it really determines everything we talked about.
And if you want help maximizing your Step 1 score, head over to medschoolcoach.com/ITB for a special offer from MedSchool Coach.
A 15-year-old boy comes to the clinic because of progressive worsening dyspnea upon exertion and chest pain for the past 6 months. He denies prior episodes of syncope, but describes moments when he feels lightheaded and weak, and these improve with rest. Physical exam shows a well-built young man in mild distress. The cardiac examination shows paradoxical splitting of the second heart sound, along with a 4 out of 6 systolic crescendo-decrescendo murmur, best heard between the apex and the left sternal border upon auscultation. Which of the following will most likely decrease the intensity of the murmur heard upon physical examination? Is it A, diuretics, B, squatting, C, standing up, or D, the Valsalva maneuver? All right, walk me through this question. So we've got this 15-year-old boy with dyspnea who is well built and in mild distress with a heart murmur. What are we thinking about?
So basically anytime I see a young athletic kid with a heart problem in a board question, they've got HOCM until I can convince myself that it's not HOCM, or hypertrophic cardiomyopathy. So walking through some of the history, like you said, he's got progressively worsening dyspnea, and even chest pain. And he's had some episodes of syncope where he passes out and feeling lightheaded. He doesn't have any episodes of syncope, but anyways, he's had moments where he feels lightheaded. So he's got something wrong with his heart. And then we listen to his heart, and he's got this systolic crescendo-decrescendo murmur that is heard at the between the apex and the left sternal border on auscultation. So that pretty clearly tells us that there's hypertrophic cardiomyopathy. It's very unlikely in a young person like this that it would be aortic stenosis that's causing that systolic crescendo-decrescendo murmur, and especially with significant enough pathology to cause lightheadedness and weakness in such a young, otherwise healthy kid. So now the question is asking, all right, what can we do on physical exam that would decrease the intensity of the murmur? So the first option is diuretics. So what they're getting at with diuretics is if we reduce preload, will that decrease the intensity of the murmur? Well, with HOCM, if you decrease the preload, that will actually increase the intensity of the murmur. And we should probably explain what HOCM is before trying to go into all of this. Okay, all right. So HOCM, or hypertrophic cardiomyopathy, it's kind of like a blockage of the left ventricular outflow tract. So it's a blockage of the blood that is trying to get out of the left ventricle just before the aortic valve. And it's caused by this asymmetrical thickening of the interventricular septum. that it basically extends into the left ventricle just before the aortic valve, So it's blocking the outflow tract. It's blocking the left ventricular outflow tract. That's what hypertrophic cardiomyopathy is. And it's usually caused, for whatever reason, by a mutation in the beta-myosin heavy chain.
Yeah, that's the most common one. I think that accounts for about a third of the genetics associated with hypertrophic cardiomyopathy, but there are others, generally involving structures of the sarcomere, right?
Right, yeah, exactly. So anyways, now that we have that description of what hypertrophic cardiomyopathy is and the most common genetic cause of it, now we want to talk about the murmur associated with hypertrophic cardiomyopathy. So similar to aortic stenosis, the hypertrophic cardiomyopathy murmur is a systolic crescendo-decrescendo murmur. So that is caused by a narrowing of the outflow tract of the left ventricle. And I'm honestly not 100% sure on a great explanation for why it's specifically crescendo decrescendo.
Sure.
I don't know if if you're more familiar with that.
Let's think about this like a balloon or something where, as you're squeezing the heart during systole, it's essentially an overriding ventricular septum, right? And as you're squeezing that, this outgrowth of the septum is slowly closing over the outflow tract to the aorta. So as you're doing this, you're closing it more, you're causing the blood to be more turbulent going through that tract. And that's causing this increase in the sound associated with the murmur, right? Similarly, as it's relaxing, the septum is moving away and there's less turbulence going through to the aortic arch, and there's going to be less of a murmur, right? Kind of makes sense there. Yeah, I kind of think about these things like a plumber. If you're going to increase the amount of fluid, then it's going to make it harder for that septum to override and cause that murmur. And if you decrease the fluid, it's going to be easier for that septum to override and cause that murmur. So
absolutely, yeah.
What's that saying is when you have things that increase your preload, you're going to decrease your murmur, and things that decrease your preload are going to increase the murmur, which is opposite of most murmurs.
Yeah, exactly. So with most murmurs, as more blood is moving across the abnormal valve or whatever is causing the murmur, you'll have a louder murmur. But with hypertrophic cardiomyopathy, by increasing the preload, you're pushing that blockage of the left ventricular outflow tract away from, or you're pushing that basically out of the way, and you're actually opening up the left ventricular outflow tract, reducing the murmur. Right, and so like you said, anything that reduces preload will cause more outflow tract obstruction, and that will increase the murmur.
Right.
While anything that increases preload will do the opposite. It will reduce the murmur, reduce symptoms. So, like you said, going through the answer choices, things like diuretics, like furosemide or HCTZ, which are very common diuretics. Furosemide is a loop diuretic. It's also known as Lasix, and HCTZ is a thiazide diuretic. So by basically getting fluid out of the body, you're reducing preload, and by reducing preload, you increase the intensity of the murmur, so that one is wrong. So the next one, why don't we go to C? So C was saying standing up. So by standing up, you end up reducing preload, and because you have blood basically pooling in the legs, and that will reduce preload, and that will increase the intensity of the murmur. Valsalva, by doing the Valsalva maneuver, you increase the intrathoracic pressure. By increasing the intrathoracic pressure, you end up reducing preload. You end up reducing the amount of blood coming back to the heart, and that ends up increasing the intensity of the murmur. And then finally, by squatting. So squatting will increase the amount of blood flowing back to the heart, because you're basically squeezing the veins in the legs, and so that will increase the venous return to the heart, and that increased venous return to the heart can also be described as increased preload. Increased preload, as we've already said, with hypertrophic cardiomyopathy, will reduce the intensity of the murmur, because you're moving that left ventricular outflow tract obstruction away from the left ventricular outflow tract, and you're opening up that space.
Yeah.
And thus reducing the intensity of the murmur.
That is an excellent explanation. And I really like this question, because if you have a basic understanding of what increases or decreases preload, you know how to get to the answer, even if you're not sure. You know, I may look at this and be like, well, what does squatting do to preload and afterload? And you know what? It doesn't really actually matter here, because I can say that if I know that diuretics are decreasing preload, and I know that standing up is decreasing preload, and if I know that doing the Valsalva maneuver is decreasing preload, well, that only leaves the one option for me, right?
Yeah, that too. Yeah, as like a process of elimination type approach. Absolutely.
Yeah, and you can do this for really any question that's asking about a situation where there's only two options, and they have to include, they're trying to get 4 or 5 answer choices in there, and they're putting a lot of the same type of thing if you can identify that that's what they're talking about. An example that I recently was dealing with were questions about hypertriglyceridemias versus hypercholesterolemias and physical exam findings. And, if you know the physical exam findings of one, then the other one is the other one, right?
Yes.
So if you know that diuretics are decreasing preload, standing up is decreasing preload, Valsalva maneuver is decreasing preload, well, the only option you're left with is the other one that's not going to be decreasing preload. They all can't be right, so they're all wrong.
Goleon's axiom.
Yeah, exactly. And that really applies.
Yeah, totally. Also, one other thing, and I honestly just wanted to get your thoughts on this. One of our professors, when asked about this very question of like why in the world does squatting reduce the intensity of the murmur with hypertrophic cardiomyopathy, he did mention the increasing preload, but then he also mentioned that you're also increasing afterload. So by increasing by clamping down basically on the vessels in the legs, on the arteries in the legs, you're increasing afterload. And by increasing afterload, you're also opening up the left ventricular cavity. And by opening up the left ventricular cavity, you open up that space, and that pushes the outflow tract obstruction closer towards the septum, opening up the outflow tract. I'm not 100% sure whether that was how legitimate of an explanation that was, and so I wanted to get your thoughts on it.
I think that's true. I have heard the same thing, that by clamping down when you're going into the squatting position, you're essentially cutting off circulation at the femoral artery, or you're making it, and you're increasing the vascular resistance at that point. You're going to be increasing the afterload, and that would essentially make it a smaller gradient between the what is this? It's the left ventricular outflow gradient. Do you know what I'm talking about?
Right, yeah. So between the left ventricle and the aorta. I guess by decreasing the pressure gradient, you would decrease the amount of turbulence and therefore reduce the murmur, I guess. That's why these things are so complicated. It just kind of depends on how you look at them. But okay. Well,
oh, I see. Okay. Well, hold on. I have this explanation now. Sorry. It took me a minute to kind of click here. So, by increasing vascular resistance, you are increasing the afterload. So, the amount of fluid that's now going to your stroke volume now is essentially going to go down, right?
Right.
Through the outflow tract. By having that less amount of fluid being pumped out for that beat of the heart, that's going to decrease the murmur momentarily, right?
Oh, okay.
So it's going to be less is going out. So there's like a lower ejection fraction, and that would decrease the murmur. Now,
yeah.
Now, if that's going to, so the other thing I'll mention, pivoting a little bit here, is like the hand grip. Have you heard of that like technique also?
Yes. Yeah. To increase afterload.
Whether or not this actually works, aside, it's another thing that's going to be increasing peripheral vascular resistance, theoretically. So because that's not in here, another reason that squatting works, right? If you had squatting and the hand grip, those both couldn't be the answer.
Yeah. And then so when I was trying to understand this stuff in my first year of med school, my study group and I were almost like about to give up on it. And we were like, we just need to come up with a mnemonic and just get through this test because this is getting ridiculous. And so we ended up coming up with the mnemonic of athletes like to squat. So by reducing the murmur and reducing the intensity of their symptoms, they like to do this. So athletes like to squat, and it's usually the young athlete who has hypertrophic cardiomyopathy, at least in the board style question. So if nothing else works, athletes like to squat. They don't like to Valsalva.
Awesome.
I don't know if that will be helpful for anyone in a pinch.
No, that makes sense, and
yeah.
I can totally see myself like going for a run and then being like lightheaded and squatting down, and that's what happens, right?
Yeah.
So that works perfectly. All right. So we hit a few of those. I think that was pretty good, don't you?
Yeah. That was fun, man.
Yeah, I really enjoyed that.
And we will end it there. Thank you for listening. Thanks to Rao Reynolds and Enter Shikari for letting us use the track Anesthetist off the 2015 album The Mind Sweep. We'll see you back next week for some more high yield learning.